only reason I sign on.
And you know, today I'm thinking to myself, I won't forget. Because now, you know, now I'm all equipped. I can I can upload the recordings myself. I can post them onto YouTube. I can post them onto the website. Now I don't have anybody else to blame if the calls don't get there quickly. So so now the calls are appearing fairly well. Let's see. And we got Bill Burhans. Hey, Bill. Hey, Professor. How are you?
Greetings.
Greetings. And I think I heard Ron and Susan say hello before.
Yes, Rick.
You did. How are you guys?
Well.
Good to hear that. And Eric Bookbinder, whose name we were just taking in vain. Are you there, Mr. Bookbinder? Oh, well, he will be. We'll see him, I'm sure, when he's ready. And who else hasn't identified themselves?
Alan Bold is here.
Hey, Alan Bold. Okay. So we got Alan Bold. So I think that's everybody that I can see. So I'll just go down this list, and if I've missed anybody, let's just see. Alan Bold, Ron and Susan. Oh, and someone else just joined us. Who just joined us?
Eric Bookbinder.
Ah, yes. Well, we called out for you before because we were taking your name in vain, Mr. Bookbinder. I told Ron Shaheen that he's going to have hair like you very soon. His hair's growing back. All right.
All right, I'll have to put up my video.
You'll have to put up your video. That's right. There you go.
Yeah, I see the similarity. Yeah. Yeah, I can see that.
So let's see. So this is who I know is on the call, and if I've missed anybody, you'll tell me. I've got Ron Shaheen, Jake Hannum, Len Sierra, Paul Frieda, Bill Burhans, Eric Bookbinder, Alan Bold, Ron Silverio and Susan LaHaye, and Mike Tamales. Anybody else? Okay. Looks like we've got a good starting call. And time, good, because there's nobody new here. So one of the things, oh, hi, Bill. One of the things that I just wanted to start off by saying is that if you haven't read it, Professor Bill posted a very good treatise on genomic testing on Inspire, and it's well worth a read. I think I referenced it in the distribution letter that I sent out. If you haven't, and there's some interesting follow-up comments too. So if you haven't seen it, I definitely recommend that you read it. And as I said to you, Bill, sadly, I didn't do a very good job starting the recording on time. I think it must be one of those calls when either Mr. Hannum forgot to remind me or he wasn't on the call, but we may need to do that session again in 2 or 3 months' time, and then we'll replace the one that we have with the new one.
That's fine. I mean, that's the reason why I decided to post the little essay that I did the other day. But it's also the case that in another 2 or 3 months' time, things are just moving so quickly.
Yeah,
that there'll be a whole new set of information to talk about. So I'd be happy.
Okay, and guys, I'm just waiting for the right time with probably the second Monday. Let me think. Either the second Tuesday or the first or the third Monday in September. I'm going to try and get Tom Harding on. Tom and Bill have spoken. Tom is a senior research executive for one of the biopharmaceutical companies in the Bay Area, comparable to the little one that got bought up for $14 billion yesterday. Unbelievable.
Yeah, I saw that.
The makers of Xtandi got purchased yesterday. And Bill and Tom is working on a drug which they think is going to be even more effective. And anyway, he's volunteered to come on and sort of talk about the second part to what Bill has been talking about, which is how you employ this knowledge of the of your gene profile to treatment, what it might indicate in the way of treatment. So we'll address that pretty soon. That should be pretty interesting. So I see someone else. Who else just joined us? Caller number 8. Stand up.
Don Price is here.
Ah, okay, Don. Good to see you. Good to hear you, I should say. So we don't have any new people. Let me run down the list and see who's got something to say, and we can jump right in. And then there are a couple of other things that I want to talk about as well. So when we get there. So Ron, Shaheen, do you have anything that you'd like to talk about tonight?
No, just listening.
Okay, Jake, how about you?
No, sir.
No.
Just listening.
Len, you want to give us a further update on how you're doing?
Sure, I can do that.
Okay. And Paul Frieder, anything for you?
Nothing for me tonight.
Okay.
Thanks.
Bill, anything for you?
Yeah, I have some maybe interesting follow-ups on the discussion that you guys had with me last week.
Excellent,
Or
excellent.
whenever it was.
Eric, how about you?
Yeah, I'd like to talk a little bit about the trial I'm on.
Excellent, good, very good. Alan Gould, anything for you?
Not yet. I got Dr. Stammer on my team, and they all haven't decided what to do with me yet. But maybe next time. I'll just listen.
Hey, Rick, I see your mouth moving, but I don't hear anything.
Same here.
Okay, there you go. I think I just hit
There
my...
you go.
Can you hear me now?
Yes.
Sorry about that. Alan, we missed that. Could you just repeat that, please?
I just said I called to listen because I got Dr. Stabler is on my team now, and they haven't decided what to do with me yet. So in a couple of weeks, I'll know more. So I'm just going to listen today.
Okay. Ron and Susan, anything for you?
Yeah, I can tell you about my experience over Hopkins with Dr. Antonakis.
Great. Yeah, we'd like to hear that. That's a good one. And Mike Tamales and Peter, how about you?
I'll come on with Mike. We got some good traction today.
Great.
We got
Okay.
some good news.
Excellent. Great, 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 great. Don Price, anything for you?
Oh, Rick, I do not have anything.
Okay. And somebody else has joined us. Who is that?
That might be me, Mike. That might be me because I lost contact. I had to redial in.
Ah, okay. So that's probably you. Yes. So I will give you you are now caller number 9, but I'm going to give you a name. So, so for those of you who are watching on the computer, I can change the caller numbers now to whoever the person is that's speaking. So, which is what I'm doing. So it helps all of you to follow who's talking. Okay. So let's start with Len. How many down? How many to go, Len?
Yeah, today was number 34, 34 down, 14 to go. Just to recap, I'm doing 48 sessions of IMRT at Sloan Kettering. 2 years, a little over 2 years ago, diagnosed with Gleason 9. I don't know if the right term is metastatic since it's not in the bone, but there was, I'll use the term metastatic to bilateral seminal vesicles and pelvic lymph nodes, but no visible bone invasion. So this is primary therapy for me, this IMRT. 34 down, 14 to go. So far, side effects have been fairly minimal.
Good. We like that.
Pretty happy with that.
A lot.
Lynn, I'm curious. This is Bill Burns. How many total grays of radiation are you receiving? Do you know?
Yes, 86.
86. Okay. I've never heard of anyone getting that high of a dose.
I know. It scared the hell out of me, but at Sloan they say that this is what they do routinely for, at least for a case like mine. And I know there aren't many other places that go that high.
Yeah. I was told that mine was, so I had 82.
I mean, I tried to talk my... You had 82.
I'm sorry.
That was probably after your prostatectomy?
No, I didn't have a prostatectomy. That was,
Did you hear me?
But they told me that was the highest dose possible, but that was 2 years ago.
Bill's breaking up for me. I don't know about you guys.
No, I can hear him quite well. I'm losing you a little bit.
It's me. Oh, it's me, yeah. Okay.
I think
Yeah.
we had too many people with their microphones open.
Dose, Bill?
You can
Bill,
answer
what
them
was the...
unless they're talking.
Yeah, if you're not Bill and Len, leave your mics on, but if you're not talking, mute your mics, and if you don't want, when you do talk, you just have to remember to open your mics, and if we don't hear you right away, we'll remind you, we'll understand.
Bill, what was your dose? Bill Burnhams?
Yes.
What was your dose?
82.
How many
Gray.
82 grays, Paul.
And that was the highest, I was told that was the highest possible at the time, at least here at Roswell Park, where I was treated. But that was also 2 years ago. So I was just curious about Len's, the fact that it was quite a bit higher. But hopefully it does the job, Glenn.
Yeah, thank you. I tried to talk the Radonc, down to something more like 81, but he said no.
Okay. And I think it's good that you're not, I think you should be encouraged that you're not seeing any side effects.
Yeah, I am really happily surprised about that.
Yeah. And
especially after my medical oncologist advised me against radiation, saying it would be a disaster for me.
Really?
Yeah, that's why I waited 2 years.
And what was the reasoning behind that?
Well, I believe it was because he knew I had a history of IBS, which I did, but that was over 10 years ago. And for the past 10 years, it hasn't been an issue for me. So, but he's thought it didn't matter.
Yeah. Okay. Well, that's even more reason to be happy then, that you're not seeing any side effects. I think that that I've been clobbered with late effects, which arise a couple of years, anywhere from a couple to 10 or 20 years after the actual radiation treatment occurs. But
yeah.
Just to remind you, in my case, almost certainly the reason why I've been clobbered is because of the BRCA2 mutation, which makes all of the normal cells that happen to be in the radiation field accidentally very sensitive to radiation. So that's not something that, you know, that should happen to anyone that doesn't have a mutation like that.
Mm-hmm.
Right. Well, I do have it as a somatic mutation, but not germline.
Right. Yeah. It would only impact you as a germline mutation in this way.
Well, is that because it's germline, it goes across the whole body, whereas if it's somatic, it's only in the tumor?
Yeah, exactly. I mean, the mutation for someone that has a germline mutation, the mutation occurs in every cell of our bodies. Mm-hmm. And so, you know, which is why they can isolate, you know, in my case, they isolated blood cells to look for the mutation. And so, you know, there's always, as best as they try to focus the beam, the radiation beam, there's always some of the normal cells that are, you know, that find their way into the field of the radiation beam. And so in my case, you know, that just meant that there was an enormous amount of damage. You know, it's the same reason why, you know, I try to avoid X-rays, diagnostic X-rays, as much as I can because of this increased sensitivity to radiation. They, you know, there's a much greater risk that they would lead to, you know, breast cancer, for example, in my case, than for anyone that doesn't have that mutation. And so for that reason, although I'm already at risk for breast cancer, I am followed in the high-risk breast cancer clinic every 6 months. Normally that would involve once-a-year mammograms, but we decided not to do those because of, you know, because all of my cells are sensitive to radiation, and it's best to avoid it.
Now, you know,
Bill, did you know?
What occurs
Bill,
to
did you
me,
know that you?
Peter, let me just ask this question and then I'll come back to you. What occurs to me, Bill, when you say this, is that maybe any man that's going through radiation, even if they have low risk 3+3, should be germline tested for BRCA before they start the radiation, I mean, or is that overkill?
No, I think that is a really good idea. Unfortunately, I was not tested until after I had gone through radiation treatment. If I had known that I had this mutation before radiation treatment, I haven't discussed this with my radiation oncologist, but I can tell you that I would have argued very strongly for a different plan that involved a lower dose of radiation.
And what's the incidence of BRCA1 and BRCA2 in the population, in the male population?
It's somewhere around, it's very low. It's somewhere around 1 to 3%.
Mm-hmm.
But I think one of the really interesting results of some of the studies that I talked about in my little essay was a study that was very recently published, which showed that metastatic prostate cancer patients, in metastatic prostate cancer patients, the incidence of germline BRCA mutations is much higher. It's close to 20%. Yeah. And so in the general populations, it's only 1 to 2%. So that would hold for anyone with a you know, less aggressive tumor. But if you have a, you know, something higher than a Gleason 6 and you're metastatic, then you know, that makes it worthwhile to test for a germline mutation, as I said in the essay.
Right, and I would think that probably it's good advice to test if you're getting radiation for recurrent disease. If your disease has not been nailed by your first line treatment, whether it's right away or whether it comes back, probably makes sense to get tested for BRCA right away if you're considering, or before you do any radiation, either adjuvant or salvage.
Yes, I think that's exactly right. I don't, I'm not sure that the insurance companies have caught up with these new data yet, and it might be hard to argue with them to pay for it. But I would definitely, push. And if anybody wants to make that argument and meet with their insurance company and needs help, come to me, and I will.
Well, yeah, I mean, you're the guy that would convince any insurance company, because if you look at what they've had to pay out for you to treat all of your side effects, it would have made a heck of a lot more sense to have tested you in the first place and adjusted the dose.
Yeah, that's a good point.
So, yeah, I just want to say one other thing, Peter, and then I'll come to you, which is that you were talking about doses. I think my dose was actually up in the 90s, but I had I had seeds plus IMRT. I believe I had 42 or 45 grays from IMRT, and then I had 50 plus grays from brachytherapy.
Okay, that's, yeah, I mean, we were, I only had IMRT.
Right, I realized you were talking about just IMRT. Peter, go ahead.
Yeah, Bill answered my question already. Was whether he knew ahead of time about his mutation before the radiation, and he stated he did not. And on the insurance end, Mike and I had a good experience today because his oncologist said, no problem with Foundation One. We have a grant. We'll take care of it.
Excellent. Okay, well, we'll certainly come to you momentarily, and I definitely want to get into that. Len, what about fatigue? How are you doing with your fatigue?
Yeah, that also is not nearly as bad as I was anticipating. I would definitely say that there's some loss of energy, but maybe I'm 80% of where I was before I started.
And are you trying to walk or do something every day, or?
Almost every day I'll go to the gym or do a little hike. Today, for instance, certain days of the week, my wife and my daughter come with me for my radiation session, and then we go to Oakland Beach at Rye, New York on the Long Island Sound, and it's a beautiful day for a beach here today, nice and sunny and dry. And so on a day like that, I don't really, well, I think most of us, the beach takes a little bit out of us. So, I didn't have any energy to go to the gym today.
Okay.
Well, I'm pretty happy. Yeah, pretty happy with the energy level thing. I've been told that you mostly feel it at the end, and I still have another, 14 to go. So we'll see if that changes.
And how's your gut doing with the white foods?
Yeah, I'm on a pretty strict diet. I find that if I do try and cheat on the diet, that I will get some GI issues. But as long as I'm true to the low fiber, low fat diet, no raw veggies, no fresh fruit, very unhealthy diet, but for a while I'm getting the radiation, it seems to be effective for keeping things quiet.
Okay. All right. Anybody have any other questions for Len? All right, Len. You're off the you're off the hot seat.
Okay.
For another 2 weeks, anyway.
for another week. So,
Bill, I wanted to ask Bill.
yes.
Now that you're taking the olaparib for your prostate cancer, wouldn't that provide protection for you from developing breast cancer?
You're absolutely right. Yeah.
Yeah.
And in fact, I discussed this with my breast cancer oncologist. I had my 6-month meeting last week, I think, and I was trying to argue for changing that to every year instead of 6 months, but it didn't work. They still want to, check in on me every 6 months. But you're right; it should reduce the chances of, any type of cancer that could be caused by this particular mutation. Right. So in addition to breast cancer, I'm at high risk for pancreatic cancer, and so I see those guys every 6 months, and melanoma, although the risk for melanoma is only a little bit higher than it is for anyone without the mutation. But in any case, for these other types of cancer, the olaparib should reduce the risk for those as well.
Very good.
It raises the question, Bill, whether people that have a BRCA mutation should be taking a PARP inhibitor prophylactically.
That is a really good question, Rick. Yeah, I don't know. This question arose in my case only very recently. It might have been Len that raised it earlier.
Mm-hmm.
But
yeah, I think that's not going to happen certainly until olaparib is FDA approved.
Well, olaparib is FDA approved, but it's not FDA approved for prostate cancer.
Right. Well, that's what I meant for prostate cancer.
Yeah, but no, I'm talking about anybody that has a BRCA mutation would want to take a PARP inhibitor to stop them getting other cancers, any cancers.
Oh, right. Yeah, those. Right. Gotcha.
And interestingly, I was talking to, I can't remember if this is what I heard on the radio, or there's a young kid at the boathouse who's he's going to be a junior at Harvard, and he's been doing an internship at Medivation. His dad's a cardiologist locally, and I ran into him as I was leaving yesterday, and I think it was either he or I heard it on the radio that said to me that one of the reasons why the price is so high is because of all this excitement over the PARP inhibitors, because I think Medivation has a PARP inhibitor that they're developing.
Yeah,
that's
correct.
I know Clovis does. Clovis definitely does, but I think that Niels told me that the PARP inhibitor that Medivation is developing is 7 times stronger than olaparib, which is, significant. And so the anticipated use for PARP inhibitors is going to be large, and I could see that people that have a proclivity to these hormonal cancers and may have some sort of a mutation in the BRCA pathway, you might be advised to take a small dose of a PARP inhibitor on a daily basis, just like they take a statin.
Rick, I'm going to look into the literature. These PARP inhibitors have been, used, even though they were only recently approved by the FDA for ovarian cancer. They've been used in the clinic, in clinical trials for a number of years now. And this question must have come up.
Right.
So I'm going to look in the literature and see if I can find anything. And I'm going to, make some inquiries around Roswell Park to see. I think it's a really good
Yeah, I
question.
mean, I'd love to hear. And, you know, the thing that just occurred to me, I don't know whether I could do this, but it's possible, but maybe 6 months from now, is maybe we could get Alan Ashworth onto this call for half an hour or 45 minutes at some point. So Alan Ashworth was one of the people that discovered the BRCA gene and developed PARP inhibitors in the UK, and he's now the chief of the Cancer Research Center at UCSF. And I've met him a few times, and he knows my best buddy from England. So yeah, we may be able to get. Sorry?
No, I was going to ask you a dumb question. That's okay. No, that would be great if you could get this fellow on.
Yeah.
And going back to the newer PARP inhibitors that are now in development or in clinical trials, you're right. Some of them are orders of magnitude more cytotoxic, specifically to prostate tumor cells. So by this I mean, you know, in a plate of cultured cells that are tumor cells from someone that had a BRCA mutation, and then compared to the toxicity of these drugs in cultured cells, normal cells that don't have a mutation, you know, the kill curves indicate, you know, 2 or 3 logs more killing.
Wow.
And that's phenomenal.
Right.
Some of it is because the mechanism by which they work is different than, for example, olaparib. And it takes advantage of, you know, some new information about how PARP works. You know, the poly-ADP ribosylase polymerase that is the target of the drug. So that's, you know, I think that this is all really exciting. I mean, not just from the point of view of a cancer scientist, but as a patient.
Yeah, and guys and ladies and gents on the call, I just want to remind you that, you know, that we talk about this not in the distant future, because what we're seeing today was first talked about to us, I mean, maybe 3 or 4 years ago. I mean, the scientists have been working on it a heck of a lot longer, but at the same time, they didn't really talk about it publicly until 3 or 4 years ago when we started talking about personalized medicine, and we have it today, and it's practical, and we're looking at it. So, you know, don't sort of switch off and think we're talking in the stratosphere, because this is a reality. I just want to remind you, where's my, I was looking for my letter opener. I just want to remind you about, it's because it's on my desk and I'll forget if I don't do it right now. There's a cancer care workshop on September 6th, Tuesday, September 6th at 1:30 Eastern on advances in the treatment of metastatic prostate cancer. So these are pretty good workshops. I know some of you have attended them before and know that they're worthwhile. Let's see, we'll have Susan Slovin, Mike Zalewski. They're both, Susan Slovin's a medical oncologist at GU Med Onc at Memorial Sloan Kettering. Zalewski is the vice chair of the Department of Radiation Oncology. Won Kim, who is at UCSF. He's one of the younger GU Med Oncs at UCSF. I've met him, but I really don't know him. Kenneth Kubert, who is an anesthesiologist, a palliative care doc at Memorial Sloan Kettering, and then some guy from Cancer Care. So that's a pretty good lineup, and I've already put it on our website under news and events, so you can find the reference and the link to it in there. The website most of you already know is ancan.org, ancan.org. but you'll be able to register. And I know some of you have already signed up for these cancer care, so you've probably, for those of you who've got the video on, there's a sheet that looks like this that'll come in the mail, and so again, I recommend it. So let's go to Peter and Mike, the tag team, and since we've been pushing Mike so hard over the last couple of weeks, and he's gotten some results, I for one am anxious to hear about what happened today when you went to see the med-onc.
Well, I don't know where to start. My PSA went up to 57 from 30 something. From 30, and they want to put me on ex-Chivo, and so they're setting that up, and then they got set up for the tumor sequencing with that fellowship program, and they were going to give me another shot. I forget the name of it. Begins with P, but it's for my immune system.
Provenge.
Oh, Provenge. Okay. Okay.
And that's kind of the progress.
You know, that I would say that's a lot of progress for, you know, from a med-onc that up to this point in time has been slow to do anything and doesn't want to give you chemo. So at least we're getting somewhere. Peter, do you want to add anything?
Yeah, I think there was a marked change in this guy's stance today. He felt it was only a 7-point rise from 49 to 57 in PSA, and Mike's only been on the full dose of Zytiga for this past month, but PSA did go up a little bit. So he feels that it's time, and we agreed to go to Xofigo. And it looks like we might be able to get it here locally rather than have to fly to Honolulu for it once a month. And he feels that it would be smart to start Provenge in tandem with it. He says it could take up to a year for Provenge to really kick in well, so might as well start it now at the same time as the Xofigo. And then I went there today armed with Bill's printout of the genetic testing stuff. I had it all printed out and stapled together, and I had it in my hand. And at the end, I brought it up. I said, "Well, you know, what do you think about genetic testing? Because some of the guys we talked to on the mainland are having success." And this guy said, "Foundation One? Yeah, I think that's a good idea. We'll set that up." And then we found out, you know, I asked if that was going to be covered by insurance, and they said, "Don't worry about it. We've got a grant. We'll just get that going right away."
Oh, that's terrific. Great.
Yeah. I was very pleased with how things went.
What are they going to biopsy for Foundation One, Michael, Peter?
Okay. I asked if we should get a biopsy, and he felt he wanted to go with the previous biopsy.
No. No.
Oh, okay.
Absolutely not.
Okay.
Right,
Well, it depends on
right,
whether,
Eric
I mean,
Bookbinder? You know, you've got...
Okay.
When was that last biopsy? It was at least a year ago, wasn't it, Mike?
Yeah.
My guess was probably several years ago.
When was that biopsy, Mike?
several years ago, I believe.
All right.
Probably when you were first diagnosed, yes?
Yeah.
Okay, which was
A while ago.
I don't even have when you were first diagnosed in my notes. When were you first diagnosed, Mike? What year?
I believe it was 2012, I believe. I gotta look at my notes also.
All right. So,
So we'll petition the urologist and see if we can get another biopsy going.
okay, if he doesn't look, I say no, 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 and I'm a layperson. Let let the expert on this call, Professor Burhans, address that. Bill?
No, I agree with you, Rick, for all the reasons that you know all about. You know, tumors evolve with time, and so if they go back to the original biopsy material, they're going to be giving a sample that's out of date. But it's possible that there aren't any. It's possible that that it's difficult to get new material, either because Mike doesn't have any nets that are in places where they're accessible. If they occur in the spine, for example, it can be difficult, not impossible always, but
He has a prostate. He has a prostate.
Yeah, he does. Okay.
Yeah.
Yeah. Then they should be able to go back and get another biopsy of the prostate. And yeah, I would go back armed with whatever ammunition you can get. To try to convince them to do that. The basic idea is that if they go back to the old biopsy material, it's going to be out of date. It's not going to give them a current picture of Mike's tumor.
Okay, we'll talk to Foundation. We'll talk to Foundation One and try to get the urologist to get on board with this too.
Okay, so if you look at the Foundation One site, it actually says on the site that they recommend that you use a recent sample, no more than a few months old. It says it on the site.
Okay,
So you might want to photocopy that. You should photocopy that statement from Foundation One itself and bring it with you to show them. That'll probably be the strongest argument.
Right.
It's as I recall, because I was just looking at the site last week, and I'm almost certain it says right there on there that when it discusses the tissue biopsies, to be sure that it's a recent, if at all possible, to use a recent biopsy. So
well, it's going to take a little bit. It's going to take a little bit of juggling because we're working with a private medical oncologist, and then we're working with a private neurologist, and to get them to kind of work together, we'll have to do a little bit of a dance here. But we'll work on it.
Okay, but don't waste your time with an old sample.
Okay.
All right, really. Okay, well that's all really good news, Mike. Let's hope that first of all the Xofigo starts to work. The Provenge, I absolutely agree. It's great to get that going, and the Foundation One hopefully shows something. When do you hope to start the Xofigo, Mike?
I'm not in any really big hurry, but I guess when they process the paperwork and make sure the insurance is gonna take care of they'll let me know. So I'm kind of in a holding pattern right now.
Okay.
As far as that goes, is there a with my meds? I I've been taking them like at nighttime all the time. Can I switch taking them from nighttime to daytime?
Well, I think it's a question of how tired you're feeling. I mean, the reason why it's recommended to take the Zytiga later is because of the fatigue factor.
Yeah.
Anybody else want to talk about timing of taking meds?
Well, yeah, definitely. Depends. It's individual how it affects you. So, did they recommend that you take it at nighttime, or did you just do that?
No, they said take it on an empty stomach, and they said most times it's you stop eating dinner at a certain time, and then before you go to bed you take it. But I don't know. I like to try taking it during the daytime. My fatigue, I have fatigue, but most of my thing is I get a lot of bone pain from doing like crazy shit in the yard. Like I'll go out and I feel from my last injury. I feel good, and I'll go out and dig a deep hole, and then for the next 3 weeks I'm hurting, and then I took the weed eater out for about 45 minutes the other day, and it felt like I fell out of the back of a pickup truck and beat with a 2x4 that night. And I just had to wait for the pain to go away, and it's all gone now. But it's when I'm not hurting, I still feel like working, and the pain kind of keeps me from doing stuff. And this last time, it's like I realized that either I got to do like about a 10 by 10 piece of grass a day, or else I got to find somebody to cut the lawn for me, which is pretty hard since you've been doing it since you were like knee-high to a grasshopper. So I don't know. It's just adjusting. And
Mike, have you talked to? I think we talked about this before. Do you have a pain doctor on your team?
Yeah, I have a pain doctor on my team.
And have you talked to him about this bone pain and what he can do for it and adjusting those meds?
Basically, it's like when you get sore, take your meds and get off your feet and rest. And that's pretty much what I do.
I think you need to revisit with him. I think that you need to revisit with him and tell him that you have a little bit more. Jeff, could you welcome to the call, by the way, Jeff, and could you mute your microphone, please? Thanks.
Sure.
Thank you. I think you probably should get with the pain doctor and talk to him about maybe taking something to cover the underlying pain, and hopefully that will address it. And don't wait until it gets too bad, because it's not a good situation, and we want to try and take care of that so you can do.
Like right now, I went from like I tolerate pain pretty good, so I went from like a 5 to like now I'm like a 0.5, but the fact that it's still there, that it bothers me, but it's it's not really game over yet. I just got to do a little bit less.
Okay.
At a time, right? I mean,
Okay.
What do you take for meds for pain now? Are there? What meds do you take for?
I got what you call codone content, and I take a Xanax for my my craziness.
Okay. So, you know, it may be that the balance of the oxycodone and the OxyContin needs changing a little bit. And that's why I would be talking to the palliative doc to see if there's a better balance they can come in with. I mean, one of them is usually taken to sort of cover underlying pain, which is why you're doing so much better. And then the other one is taken when you have critical pain where there's, you know, suddenly an issue. But just have a chat with him, call him up and see if they can see what he suggests.
I have an appointment with him coming up this week also. Yeah.
Okay.
I'll see what he has to say.
Okay.
Yeah. Thank you.
Okay, one other thing, Rick, is where we did not get any traction because Mike has started to fail on the Zytiga. I pressed this guy about the ARV7 test, just in case Xtami was in the works down the road, and he didn't want to hear about that at all. He didn't feel that was a valid test or the way to go. He's of the mindset that you try things until they fail.
Well, I mean, I still think, Mike, and we've said it enough times, you got to get yourself, even though this guy's giving you something, you got to get a genitourinary medical oncologist to run the show. And, you know, we're sort of patching it together here, but it's not the way to go. And we want to keep you around, and the only way that's going to happen is you've got to get a GU med-onc to run this show. But we've got to move on.
Okay, yeah, I'm taking up a lot of time, yeah.
Okay, we got to move on, but it is an issue. Peter will talk to you, and you know what? Think about coming over to when the PCRI conference is on, and we'll do our best to try and get you in to see Peter's group in Los Angeles. That, you know, you could come over the same time as Peter. Okay, so I'll leave that with you and Peter. So let's move on.
Thank you, Rick.
Pleasure. Let's move on to Ron and Susan, because we haven't heard from you in quite a while, and and tell us how you did with Antonakis. For those of you who don't know, he is a genitourinary medical oncologist at Johns Hopkins, and he's pretty well known. He's actually one of the guys that developed this ARV7 test. And I'd love to be a fly on the wall if he had a conversation with the medical oncologist in Maui. But anyway, go ahead, Ron.
Well, I'm ending my, I'm getting close to the end of the standard treatments. So Susan and I decided to go to Antonakis and see what he's got available up his sleeve. And he spoke about the AR-V7.
Mm-hmm.
And he was saying that 30% of the guys have this stuff in their blood, 70% don't. The 30% that do have it go on to these two high-dose steroids, and that's where you go from there on if you have the 30+, you know, the 30% that have the AR7, V7. The 70% that don't have the thing in their blood, they go on to do the radium 223, and then after that you have to go on to trials, and there is one trial available right now, and it's his writing on this thing. Listeria vaccine IV, along with something else, and it's big medical names. I can't even read them. And that's what he was saying. That's the next step for me.
So you
and he said, well, I'm on the Zytiga.
Right.
Okay. No, Xtandi. I'm sorry.
Right.
Xtandi.
That's what I thought. Right.
Yeah. And he said, soon as your PSA goes up one notch, give me a call. I'll have you come in and we'll do the blood test.
Okay.
And I had a follow-up right after I had an appointment with him, and my PSA was 27, and then at the follow-up, after taking Xtandi for like a month and a half, it was down to 15. So all the numbers have gone down. So he says, well, as soon as it goes up, we gave him the good news, and he says, great news, but as soon as it starts going up, give me a call.
And what's your latest PSA?
I'll find that out. Well, right now, the latest one I have is 15.
Is 15. Okay, yeah, I have that one recorded.
Yeah, that was on July 20th.
Okay.
And I have a follow-up appointment the beginning week in September, so they'll probably do all that stuff too.
Now, Ron, what about getting your tumor sequenced?
Nobody said anything about that. Or at least he hadn't said anything.
Well, my recommendation to you, if it were me, I would be wanting to get my tumor sequenced at this point in time.
Okay. And is Antonakis the guy I would see and speak to about that particular thing, or can I just go to my regular medical oncologist?
Either. Antonakis would be in a better position to read the results. He's going to make a lot more. It doesn't really matter who orders it. In terms of interpretation, he's the guy that you want to interpret it.
Okay.
And not your local guy.
Yeah.
Having said that, it's sort of a question as to where they can take a sample. Where do you have metastasis, Ron?
Both hips, a couple of spots in the spine, and that's about it.
Okay. And you don't and you do you have a prostate or not? I can't remember.
Yes, I do. Yes.
Okay. So the easiest place to take the sample is from your prostate.
Correct.
Other than that, they could take a sample from your hips.
Correct.
So you have spots where they could go, but like I say, that the most simple one would be just to do a quick biopsy, prostate biopsy, and that would give them a sample, and then you ship that off to Foundation One and see what it says, and you're far enough along that one would hope to find some sort of actionable gene there. And I think you have to insist and say, look, it's time, I want it done. And you could do it with your local med-onc and the urologist.
Yeah, I think I could, yeah.
And like we've said a number of times, first of all, it's covered by Medicare, and secondly, even if it isn't, there's so many workarounds now, and Foundation One has made it really clear they'll do everything they can to make it financially feasible for anybody that wants a test.
And the oncologist has to contact them, or do I personally contact them?
No, I think you can contact them, and they're from what I gather. Well, I actually have spoken to them one time, but they are very friendly and helpful.
Oh, okay.
But
Okay.
I believe the test has to be ordered by the doctor. Does anybody know the answer to that?
Yeah, I think you can have the test and without having a physician order it, but it'll be difficult to get your insurance company to pay for it. I think generally the insurance won't pay for it unless it's ordered by a physician.
Right.
Okay.
But
Yep.
I think Ron and Susan, I think you got to insist that it's time, and you want it sequenced.
Okay. Sounds good.
You know, over the next month, you'll get the results back, and you know, let's see, because that could change. Now, the listeria, yeah, I mean, this is a trial that's been around for a while. There's a doc in Jersey that's been pushing it. We had a guy that was on the call pretty regularly for a while who was thinking about doing it. And also, it's been offered to Jim, somebody help me, the professor at Rutgers. What's his last name? Sorry?
Was it Jim Marshall?
No, not Jim Marshall. Jim Marshall's the Aussie.
Jim Cameron.
Jim Cameron is Venice Jim. It's the other Jim. Hold on. I'll tell you. James, I know because I've got it right here. James. Oh man, why doesn't it give it me when I? No. Jim Harrington. Jim Harrington. So Jim Harrington, and I can put you in touch with him if you like, if it becomes an option, but Jim Harrington has been offered this listeria test. It is an immunotherapy test. It's an immunotherapy treatment, and the listeria is used to carry the, or listeria is, I'm going to get out of my depth here, Professor, before too long. I think the listeria is carried into the immune system and somehow or other combines with the prostate cells to create T-cell antibodies that will attack it. Bill, help me.
Okay, to tell you the truth, I don't know very much about this test, but I'm guessing that the listeria is used as what's called a vector. It's just a DNA molecule that something else, a gene, is cloned into, and the gene is expressing something that is serving as an antigen. So it's relatively unimportant in the scheme of things, but I think you got it basically right, that it's going to do something to either activate T cells or attract them or something like that.
Right. And so yeah, I'm definitely aware of it, and we have heard about it. And when we have the call with Tom Harding from Clovis, he'll be able to explain it clearly.
Okay.
So
I'm going to learn more about it before our next call too.
Okay.
I will say something intelligent.
Okay. So that sounds good. And how are you feeling in yourself?
Pretty good. I got a little arthritis in my left hip,
Mm-hmm.
and it's the same pain I had like 8 years ago when I injured my hip.
Mm-hmm.
And in fact, when I was diagnosed with the cancer and the mets in that hip, and I was complaining about pain, my wife says, "Oh, you got to go see somebody about that." So we went to go see this bone guy, and he looked at it and he says, "Oh yeah, you're riddled with arthritis in that hip."
Mm-hmm.
So.
Mm-hmm. Mm-hmm. Mm-hmm.
So other than that, I take extended relief, what do they call it? Tylenol.
Mm-hmm.
And they say to take 2, I take 1, and that's enough for me. It lasts when I have to do stuff.
Okay.
And other than that, I feel great. In fact, it's scary I feel so well.
Good.
because I had just come off of 5 rounds of docetaxel.
Right.
And that docetaxel, it's a nasty thing.
Yes, there are other people on this call who would agree with you, I think.
Yeah, and I'm glad she gave me the carbotaxel first, because I went on that for a year.
Right. So, come back to us and tell us how you do with your sequencing, because I think it's time.
I shall.
It's time for that. Eric, tell us about this trial that you're on.
There you go. I had to unmute. So I'm on a BET inhibitor. It's only known by its number and its study number, so they don't have a name for it yet. So I've been on it. I started on the 15th, and yesterday. So this is a week after the first. It's taken in pill form. I take 4 1-milligram pills every day. They were adamant about how the pills be handled, that they stay in the bottle, that no one else handle them, that I bring the empty bottles back to them. I have to bring all. They gave me 4 bottles with 30 each. It's sort of an odd number considering I'm taking 4. And so every time I come in, I have to bring the medication with me. So yesterday I had 9 blood tests and 9 EKGs. So they track it down there. They want to track how the medicine goes into the bloodstream, and how long it stays there, and that's what they're all tracking. So I started out. I got there at 7:30 in the morning, and I didn't leave till 6:30 at night. And the wonders of being in a study, but so I won't know, if anything's working for a while, but they do it in cycles, and a cycle is 4 weeks. And at the beginning of each cycle, I'll go through the having EKGs and blood tests. They were telling me that the EKGs they're doing mostly for, they have to do them for guidelines, but to do them with each test, we're talking about some other drug that had a study done, and they didn't save the EKGs, or they didn't do them, and they spent 3 additional years trying to get it approved. So that's their rationale for doing all the EKGs.
Now,
go ahead.
This is a phase 2 test? I can't remember. Or phase 1?
1B.
This is phase 1B. Okay, that's probably why there's so much. And what does 1B mean? It means that they've already tested it and they're retesting, or what's the B for?
I think it's where they're determining dosage.
Okay, I thought that was usually a phase 2.
They're doing. Yeah, it could be, but at this point they're doing a study comparing how it works with enzalutamide and without. I'm part of the without study.
Okay.
Since I was coming off of enzalutamide.
Who's the PI?
So that's, well, Agarwal is in charge.
Okay, that's probably who it is. Do you like him?
Oh yeah, I found him very nice, and I've seen. They have the pharmacist and the physician's assistant, and then there's the admin, and so there's a whole crowd of people that I've met as part of this. So.
Between us boys, if you can get your records switched over to Agarwal instead of Amy Lynn, I would encourage you to do that. Going forward, whatever happens.
Right. I haven't seen Amy Lynn in 5 months or something.
Okay.
So I'm not really seeing her as part of this study. There's nothing going on with Amy Land. They're sort of coordinating still with the Berkeley Med-Onc.
Okay. So for the people on the call who are wondering, go ahead.
No, there's just one more thing that the Zometa, they want me to stop doing it monthly and go to once every 3 months, quarterly.
Mm-hmm. Yeah, I mean, it has
They're really worried about that.
It has a very long half-life, so I don't think that's a big deal.
Right. I'm having problems with a tooth, and nobody wants to touch it because of the worrying about the
Okay,
Zometa.
so do you have a dentist? When you say no one wants to touch it, what I would like to suggest to you is that you put your dentist in touch with the oncological dental specialist that we identified at Memorial Sloan Kettering, because she's offered to talk to any local dentist that needs help. And this is somebody that Richard Foodie has been seeing. Memorial Sloan Kettering has a oncological dental group, and I'll send you her details.
Okay, the people at UCSF said they were going to put me in touch with their specialist there. So.
Okay, well that's a possibility too, but I'll send you the details anyway.
Okay.
I didn't realize that they had a specialized dentist at UCSF, so if they do, would you let me know? That would be good to know.
I will.
So I just wondered if you could maybe, if it's been explained to you, or if not, I know Bill has looked at this BET inhibitor, but just tell the guys on the call how you understand it to be working and why it's might be a good alternative to somebody who's ARV7 positive or who might have failed Zytiga and enzalutamide as you have.
Well, essentially, what I know, Bill may know more. Bill, do you know about it?
I know very little about it. I did know a lot, but I've forgotten to tell.
Okay. Well, what's been explained to me is that it's essentially like, abiraterone and enzalutamide, that it deals directly with the cells in the receptors, and this one apparently is much more effective in keeping the receptors from accepting the testosterone or artificially connecting with the receptors.
Right. And anything that does that is good. Yeah, I mean, I was interested in it because it's in a different class of drugs that interacts with chromatin or specific types of chromatin, but that's neither here nor there. I mean, that's interesting to cancer scientists, but I don't think to anyone else.
Bill, I recall that the way you explained it to Steve Bornstein and myself was that you felt that one of the things it did, this BNT inhibitor, was to sort of crowd out the receptors so that nothing could get to them. It sort of swarm the receptors so that they were unable to feed.
Keepers, you have such a great memory, Rick. Yes, that was it. Right. Yeah, so it competes with for those receptors, and basically exactly what you just said.
Okay.
It wins the competition, and because it's not the real thing, then it the real thing can't work.
Mm-hmm. Good.
I'm not being very articulate here.
No. That's great. When is your next follow-up, Eric? Another month, or do you have to do any testing between now and the next time you see him?
They do every week. They do blood tests.
Mm-hmm.
So next Monday I go in for another blood test, and then at the beginning of each cycle, that is every 28 days, they will do more extensive testing, and they won't do a scan until 2 full months or maybe even 3 before they'll do a PET scan. But I'm also doing an experimental PET scan, which I had done before I started the inhibitor, and that experimental PET scan is going to be repeated in September, and so it's sort of secondary. It's 2 different studies, so it's not the one that's being done for the study, but it will be done anyway. So it'll be interesting to see. I think I told you that it's with a new staining chemical, and it did show. They said it showed there was some uptake in the lumbar region. So I'm hoping that will disappear by the next time they do this.
Now, this PET scan test is only for prostate cancer, or it's for multiple different cancers?
It's different cancers.
Different cancers. So you're like one of the prostate population in the trial.
Yes.
When you say that it's there's a new cycle every 28 days, does the dosage change every 28 days, the pills that you're taking, or what identifies each cycle?
It's just their definition of the cycle, and they may change the dosage. They may change the medication. That's one of the reasons why I have to bring it in every time, because if they decide to change it, then they will reissue a new set of pills. I'm not sure why they gave me maybe it's just easier for the pharmacy. They gave me, the 4 cycles worth on day 1, but we'll have to see how it.
I'm just curious. Do you know who the manufacturer is?
Gilead.
Oh, Gilead.
Gilead, that's it. Yeah.
Oh, Gilead. Oh, okay. They're huge already. That's interesting. Okay, Gilead is Gilead's an Israeli company with facilities here, and they're huge in making generic drugs. They're a big generic drug producer. So okay, all right. Well, good luck, and hopefully we'll see. What's your I know that your PSA is always very low, which is the nature of your disease, but the last time we talked about your PSA, it was 4.8 at UCSF and 5.7 at Outer Bates. Give us the latest update.
UCSF has a new one. It's now 5.8 at UCSF, and I won't get tomorrow. I go for the Berkeley one to find out what their shows.
Okay. And again, guys, you've heard me say this, but you can't judge any individual on the level of their PSA. I mean, Eric has a disease that just doesn't make PSA, but is extensive. Somebody like Eric could have a PSA in the hundreds quite easily, and it's just the nature of our disease. So I still want to touch base with Jeff, but I'm going to go to Bill first.
Rick?
Yeah.
I got a question. This is Jake.
Yes, please, Jake.
Okay, you mentioned that Eric is one of those that makes low PSA. How do you know that you're one of those people? How do you know that it's just the medicine is not keeping it low, as opposed to it's not working, but you make low PSA? Do you understand my question?
Well,
I do.
Let me tell you the history. My history was that I had my PSA was running, in 2.5, 2.3, something like that, and then for other reasons, I had one. A year later, I had another, and 6 months later, I had another, and it went 2, 3, 5, 4, 2, 3, 3, 5, 5, 4 in that time. So it just all of a sudden started shooting up, and it was still low, 5.4. It's not, but it was over 4. And they said, well, let's do a biopsy, and I was 6 out of 14 were cancerous. One, I had a Gleason 8 in several of them, and then I had a prostatectomy, and they evaluated it as a Gleason 9, and with involvement of the seminal vesicles, and then a month and a half later or 2 months later, when they did the PSA, it was almost 3, so it should have been 0. And so then that's when they did a bone scan and a PET scan and found that it was already in my spine. They were going to radiate the prostate bed, but they did the PET scan first, and when they found that it was already in my spine, they didn't bother radiating the prostate bed. So with treatment, I was taking Casodex, and the PSA started shooting up, so then they switched me. Oh, and they also did radiation to just for pain purposes, and the PSA went down to almost 0, and I stopped the Xtandi, and within a month and a half, the PSA had gone up to 3.5. So I started the Xtandi again, and it basically worked for only a very short time, and my PSA has continued to go up, and that's why I went for the trial. The highest my PSA has ever been was 6.5.
So, when somebody has metastasis, notwithstanding they're taking all these drugs and they're castrate resistant, and as a castrate resistant man, it still only gets to 6.5. It would indicate that they just don't make a lot of PSA. I mean, we know plenty of men who are castrate resistant who are managing their disease comfortably, and it's in the hundreds. So I think that's the conclusion when you look at when you look at Eric's history, Jake. Some people just don't. Some people just don't make.
This is Bill speaking. And usually the low PSA producers, that corresponds to a different pathology.
Yep.
So Eric, were you told that you had something other than the, run-of-the-mill prostate adenocarcinoma?
No. Not, I mean, the most they've said is that prostate is individual, so each of us has to deal with the disease that we have, and generalizing it is not easy.
Well, that's what makes me wonder, because in my case, the highest my PSA ever was 26 or 25, and then I had the cryo, and it never went down to where it should. But even now it's going up, but it's still only 3. Do I need to be concerned that it's not going up faster because I'm a Gleason 8? You understand what I'm saying?
I do.
Yes and no. I mean, look, again, I'm not a doc. If I had your situation and I was looking at it, you haven't been through the treatments that Eric's been through. I mean, the fact is that Eric failed Zytiga and Xtandi. So that's a pretty big red flag to say that it's complex disease.
Right.
You've been on, I can't remember, you're on Xtandi, aren't you, Jake?
No, I'm just on Lupron and Casodex.
Just on Lupron and Casodex. So it seems like it's the hormone therapy is managing your disease quite well.
Even though it is going up.
Even though it's going up, because it's not going up that much, and the fact is that at one point it was as high as 28.
Before I had treatment, right?
Before you had treatment, and before Eric had any treatment, it was the highest he ever got to was about 6, even with, or less, even with complicated disease.
Even before the prostatectomy and everything?
Yeah, what was the highest you ever got to, Eric, before you had any treatment?
5.5.
5.5.
Okay. Okay.
So, but you know, it's worth bearing in mind. I mean, and you know, there's levels all the way in between as well, Jake. So some people make huge amounts, some people make very little, some people make somewhere in between. People that have non-adenocarcinoma disease, like small cell disease, neuroendocrine disease, may make tiny amounts.
Right.
And one of the big problems with people that make very little PSA is trying to evaluate whether their disease is recurring or not. There's a guy like that locally here, Steve Brown, who is a warrior, and you know, in the best of times, and he's been followed by Peter Caronell for years and had I think his disease was 4+5, his post-pathology, and so small changes in his disease, in his numbers, may be a lot more significant to him. I mean, he varies around 1 to 2. I'm going to have to let this. Sorry about this. My phone's ringing and I can't really stop it. So, maybe I can turn the ringer off. I don't know. So, I'm sorry. It'll just have to ring in the background. Yeah, you raise a good point. The one thing I did want to ask Eric before we leave is, have you had any discussions with Agarwal or anybody else about resequencing your tumor?
No. I will ask them again.
Yeah, I think you owe it to yourself. It needs, now they could probably do it as part of this trial. They could certainly send it to the to UCSF 500 for you, but you know, it does need to be done, and in the worst case, the liquid biopsy could be done if there's no convenient place. But I know if it were me, I would want to. I know that they did it, but they did it on an old sample, and I think you got to do it on a new sample, as we discussed earlier on.
Yeah.
Because it might just point something out really significant, Eric.
Sure.
Okay.
All right, I'll bring it up. Please.
And if they won't, then get your medical oncologist at Outer Bates to, yeah, just you know, worst push comes to shove, the worst you can do, you'll take a blood sample and you'll send it down to you'll send it across to Foundation 1, and it won't be as good as if we had a tissue sample, but at least it'll be an up-to-date. Okay. All right.
Liquid
so
yeah, the easy way to go.
Sorry, Jake.
Liquid sounds to be preferable to me, is because it's easier.
Well, you see, the down, it is easier, but the downside is the panel is much more limited.
Oh.
And
it's the difference between, I think, somewhere around 60 genes that are tested in the liquid biopsy versus more than 300 in a tissue biopsy. And that's a big difference. You get a lot more information from more than 300 compared to 60.
So Bill, let's come back to you. You had some more thoughts, and I actually have one other question for you, which I posed on Inspire. I am not clear at the difference between gene and genome.
Okay. Let me just quickly bring you up to date on the discussion that we had last week or 2 weeks ago.
Yeah, on your bladder.
Yeah. I have to tell you, I'm falling asleep here. So
okay,
if you see me just nod over in the middle of this discussion,
okay, well, we'll let you go after this. We'll excuse you after this.
Yeah. So I saw my urologist. So I'm seeing, in addition to all these oncologists at Roswell Park, I am being seen by a urologist who is not a cancer doctor. but she has equipment and expertise that they don't have at Roswell Park. So she's helping me with my radiation cystitis issues. And so we have been talking about bladder installations, which are, they pump, they don't pump, they introduce into your, they meaning the doctor or a technician introduces a solution into the bladder that deals with some of the damage from radiation, which is what I'm dealing with now, 2 years after I had radiation. So some of you guys have suggested that I talk to her about changing to a solution that they would put into my bladder that's different than the one we're using.
Right.
Which at the moment is lidocaine and heparin and sodium bicarbonate. And so I talked to her about it, and she agreed that it needed to be changed to something that I guess basically would be more aggressive in its effects. And so we're going to be doing that the next time that I have one of these. But she also suggested, and I am accepting her suggestion, that I have Botox injections into my bladder. So I'm just telling you guys this as a matter of information in case you find yourselves in the same boat. The Botox, so part of the problem that radiation cystitis causes is uncontrollable spasms, because nerves are firing all the time that shouldn't be firing. And the Botox will help to basically just calm those nerves. So we're going to try that as well. If it works, then it should, she told me that it should help with the pain for anywhere from 9 to 12 months. So that would be great. I'm having a terrific problem with pain, and you know, when I'm trying to avoid, I'm already taking a huge amount of narcotics, and I'm trying to avoid increasing that because of the fatigue issues that it's causing. So if the Botox can solve that problem, it will be wonderful. In addition to my having the youngest looking bladder in the Mississippi. So anyway, I just thought I would let you know about that.
Well, that's great, and I'll be sure to communicate that to Jim Marshall in Australia, because I know that he was the one that had some expertise in this, and I'm sure that he'll feel good that his suggestion of formaldehyde is something that has been taken up, and it'd be interesting to check with him too what he knows about Botox, if he knows anybody who has had Botox.
Yeah. Is he a physician? Is Jim Marshall a physician?
No.
He's okay.
He's just an educated advocate.
Okay, great. Okay, so genetics and genomics, or genes and genomes.
Yeah.
I did post something about this on the
great!
website.
Thank you. Thank you. I haven't looked.
You know, basically, your confusion is shared by many, many others, and part of the problem is that professionals use these terms interchangeably, even though that's a big mistake. And so I'm guessing that that is the source of the confusion for you. But basically, a gene is a unit of information that encodes the information for a protein. I mean, there are genes that also, you know, do things that other than encode for proteins, but the ones that encode proteins are the ones that we're interested in as prostate cancer patients. So it's, you know, it's just a sequence of the basic building blocks of DNA that are specific for a specific protein, and when that sequence changes, that's a mutation. And so, you know, if you're, the genetic test will look for those changes by sequencing the DNA. Does that all make sense?
Mm-hmm.
A genome is the total sum of all of the genetic information in an organism. So in humans, for example, that includes somewhere around, I think, 19,000 genes, and a lot of you know, DNA in between those genes as well. And so it's a genome is a much broader it's a much broader description of genetic material, and it's usually I'm fumbling here. It's generally used in discussions of the activity of genes. So, you know, a lot of genome science these days, genetic science basically looks for mutations and asks, you know, how they occur and where they occur. Genome science, it much more frequently asks about the activity of those genes or of specific genes. So how many proteins are there in a cell produced by that specific gene?
Mm-hmm.
Are there, you know, sometimes the genes are amplified, and so there'd be tons of proteins, and that can have deleterious effects. And and they contribute in some cases to, you know, the pathology of prostate cancer. So genomic tests that I refer to in my posts are usually the tests that are offered by companies like Prolaris or what's the
Oncotype DX.
Oncotype DX, right? And there are several others. So what they're looking at in tissue samples that they receive is not the DNA, but the product that is encoded by the gene. So proteins, or the intermediary between DNA and proteins, which is RNA. So, you know, some companies look at levels of RNA for a specific protein, and some companies look for levels of protein. And that can be of great prognostic value in particular. If you have, you know, normally the levels of proteins are very tightly controlled. And in cancer cells, very often the levels of protein encoded by a specific gene will be much higher than they're supposed to be, sometimes lower too, but usually higher. And so, you know, if they are, then that can be an indication of more aggressive tumor, for example. And these companies like Prolaris look not at just single genes, but at a whole panel of genes that they've determined through their research is characteristic of the signature of a very aggressive tumor. And so it, you know, it allows them to tell a patient, or the, you know, the results of that test when they come back to the oncologist allows them to tell the patient that it's a, you know, very aggressive tumor or not, and that sort of thing.
Mm-hmm.
So
Bill, if
they're generally referred to as genomic tests, and genetic tests are the ones that ask, you know, whether or not a gene is mutated.
So
is that
yes,
clear?
it is, because I was going to say to you. So what Foundation One is doing, or Caris Life Sciences, or somebody like that, that's really a genetic test as opposed to a genomic test, because they're really looking at the genetic profile of the tissue that they've received.
Exactly, that's correct.
Okay, I got it. Any questions, guys? Anybody? Does anybody want to come back to Bill on any of that?
I have a question. Other than the BRCA genes, are there other actionable genes that are that people are getting treatment for?
Yes, there are. So one of the really surprising results. All this is brand new. It's all within, this is information that's developed just in the last year or two. And one of the things that's been learned is that metastatic prostate cancer patients often have mutations in genes in the same genetic pathway as BRCA1 and BRCA2. So genes like a gene called ATM are frequently mutated, and there are a bunch of others in that same pathway. And they're all actionable specifically with olaparib, which makes sense because olaparib is really attacking the function of that pathway, that occurs downstream of all of these genes. But then there are many other genes that are actionable, meaning that they will respond to drugs that are already on the market. And there is a recent study which demonstrated that about 90% of all tumors from metastatic prostate cancer patients have an actionable mutation. So this is just astounding. And this is, I think, one of the reasons why Rick is harping on genetic testing, because it means that all of us, almost all of us, can be treated almost certainly with, 90% of us are likely to be able to find a drug that's going to have an impact on our tumor.
Well, let me just say may have an impact. I mean, it's not a silver bullet. If you listen to...
No, I said likely. Right. No, I said likely. I didn't say it definitely would.
Right. If you listen to Larry Fong's presentation, which is well worth listening to, and also it's listed on the website if you don't have the link, Larry makes the point that these drugs are only effective in 10 to 30% of the people that have the appropriate mutation. So just because you have the mutation doesn't mean the drug will work, but you have a good chance that it might work.
Right.
Like with Bill, God bless him. I mean, it worked for Bill. Now, olaparib didn't work for certain other people's. Dominic Arestisol had a CDK mutation, which is in that BRCA pathway. It didn't. It may have done something for him, but it wasn't. All it did is it slowed it down. It certainly didn't do enough to manage his disease for a long period of time.
Right. I think, unfortunately, in Dom's case, though, Rick, I think that it wasn't it may have, olaparib may have done a better job if Dom had more time.
Mm-hmm.
I mean, it sometimes takes a while, as you, I'm sure, know, for the levels to in the circulatory system to build up to the point where and he was, he was going on and off olaparib. He went on it, then he came off it, I think, for a while, and then went back on it. So in his case, it may have worked, but you're absolutely right. It doesn't. Nothing is guaranteed, and
right.
With the study that's indicated that 90% of all tumors have an actionable mutation, that just means that, as Rick said, it's worth seeing whether or not one of these drugs is going to work for you, but it may not.
We'll take one more question on this, and then I want to give Jeff the last 10 minutes. So was it Len who was trying to say something before, ask a question?
No, it's not really worth wasting time on. Go ahead with Jeff.
Okay. Well, if we have any time left at the end, we'll come back to you. Although I'm going to give Bill permission to sign off any time. So
Okay,
thank you so much, as always.
Okay, you're very welcome. And I'm really enjoying this. I hope you all have a good couple of weeks, and I will talk to you
soon. When are you leaving for Vermont?
Tomorrow morning.
Okay,
the plane leaves at noon.
Okay, I told Bill to make sure he takes his Michelin suit with him. We don't want him falling over again and doing anything to himself on this trip.
Yeah. Last time I was in Vermont, I broke a whole bunch of bones, but no, there's no ice up there. I don't think this time. So
you'll find it. You'll find an ice cube to slip on. Take that Michelin suit with you.
Right.
Okay,
and Len, I'll be flying right over Danbury and Brookfield again.
Yep, honk the horn.
Pilot the honk.
Okay,
Bill.
Bye.
Bon voyage.
Jeff, how are you? Tell us about how you're doing.
Well, to hear everybody else talk, I'm not doing very badly at all. Unfortunately, my PSA starting back in June went from 0.9. At the end of July, it was 1.3. Midway through August, it was 1.45. So that, from its low point at 0.15, is up 967%. That's a lot. Anyway, as you know, I have changed to a med-onc down in Portland, and I'm also working with a rad-onc at the Harold Alfond Center for Cancer Care. He has already done one thing with me, and that had to do with gynecomastia. He gave me 2 treatments of 600 rads each to each breast, and hopefully that's going to slow or stop the growth of additional tissue. So we'll see how that goes. He was going to start me on radium-223, Xofigo. As I wrote to you, on the 29th of July, I had an orthopedist go in and take out my old knee and put in a new one. The one good thing that he noted was that, now I did have originally bone mets to femurs and hips. Well, he went in and he messed around with the femurs and the tibia. He found no bone mets in either. So that was positive, very positive to me. I don't know why my PSA continues to go up. I am on Casodex. I am still on the Firmagon. The Casodex does not seem to have slowed the slope of the increase at all. It went up 0.15 in 2 weeks, which is, to me, not good. We will find out Friday when I see my med-onc what we're going to do from this point.
So typically what often happens when you start to see a rise like this, and they may want to see it get a little higher, by the way, than the 1.5. That's not unusual. But the first thing they do is just take you off the Casodex. Because the Casodex can work to promote rather than reduce the disease at some point in time. And Bill did explain to me the reason why on the last call, because I always said they don't know, and he said, well, they do know, but I can't remember what it was. If anyone else who's on the call can remember, they can pipe up and tell us. But it's pretty common to take you off the Casodex and see if that has an impact, and then if that doesn't have an impact, then to think about what to do next.
Yeah.
Hey, Rick.
Yes.
This is Len. If you want an answer to that question, what I've read is that Casodex is both a antagonist, which means it's blocking the receptor, and a partial agonist. And an agonist, of course, is a stimulator of the receptor.
Mm-hmm.
So at some point, I suppose that if the antagonistic action of Casodex is no longer effective, then you're left with the partial agonist effect, which means it's stimulating the receptor.
Right.
Yeah.
Thank you. Thanks, Len.
I have read the same thing.
Okay.
Yeah.
So that could be the next move, and then given that you've done a bunch of chemo, the question would be where to go next. Now, I think that you were going to check into Provenge.
Yes, they do Provenge down in Portland, Maine, and it's something that I broached with my med-onc, and I'm planning on broaching that again. I also want to make sure that we get the ARV7 splice variant test done, because
definitely.
if that is, I think if it's positive, enzalutamide and abiraterone will not work.
That's right.
So, that's I guess my big point with him on this next go around Friday.
Right. Anybody else want to suggest anything to Jeff for the appointment coming up this week?
Jeff?
Yeah.
This is Peter. Based on the comments by your orthopedic surgeon, are you going to have another scan done to verify that you've actually got a decrease in the Mets?
I would certainly hope that my rad-onc will consider that for sure, for the simple reason that we need to find out where this additional PSA is coming from. Is it bone Mets producing it? Will the Xofigo work to knock the bone Mets out? And a follow-up bone scan after the 6 months of Xofigo, I would think, prior to starting it and after finishing it, to find out if it actually worked. That's my thinking anyway.
Well, I mean, again, I'm not sure. I think that's something you can also discuss with the medical oncologist on this week, because it's as much in his bailiwick as it is in the radiation oncologist's bailiwick.
Sure.
And it's a good point. Yeah, it's a good point, Peter. Thank you. Anyone else have anything for Jeff? Jeff, do you have any questions for anyone on the line?
The only thing is, I hear people talking about much higher PSAs than I've got, and I look at mine and I say, gee, I'm not doing so bad. I'm not having bone pain. I'm not having a lot of things that these fellows are running into. The only pain I've got, and that's not so bad anymore, is walking a lot, and that gets my leg to saying, hey, cut it out. We're not used to doing this.
Right.
But I'm going up and down stairs now. I'm walking, I'm exercising, and as of today, I've gotten up to 112 bend on that knee, which is 8 degrees to go.
That's great. That's great. Now, I mean, you're certainly not amongst the people that doesn't make PSA, because you had PSAs in the 1700s.
I started out with 1860. You're right.
There you go. So you're not like Eric, for example, who never made a lot of PSA. So to me, what we're seeing is that the treatment is working, and the fact that your PSA isn't going up that quickly is probably a result of the chemotherapy that you did and the hormone therapy and what have you. So yes, you may be starting to become castrate resistant, but the disease is still being managed.
Yeah. That's probably the way I feel about it too. It's just that when I see 1,000% rise in PSA, to me that's a lot.
Yeah, but you got to look at the. I mean, you know, you're a scientist. You got to look at the base.
Yeah.
You know, it's not 1,000. It's not 1,000% rise from a base of 10. It's 1,000% rise from a base of 0.1.
That's right. That's true.
You know, so you got to take that into account. So anyway, guys, we've managed to kill the 2 hours again pretty comfortably. This was a good call, and I think I will probably identify it as just for the last 15 minutes as a call worth listening to for some more genetic and genomic information. And we'll be back again on Monday. Everybody keep visiting the website. There's new stuff there every day. I put up a bunch of webinars today that are worth listening to. I'm still looking for a moderator for the Caregivers group. I've got a couple of leads, but I don't have anybody just yet, so I'm still looking for recommendations. And I'm also very open to starting calls for other situations, conditions, and diseases. If you know of a moderator that would like to run a call online, you know, you may have friends that have other situations and very knowledgeable about their disease and feel like they would want to moderate a group, and they are in touch with people that would want to gather online. And I mean, I can't provide them with a core group of people. I mean, maybe somebody with breast cancer, I don't have those people initially, so they would have to be reaching out, but we can certainly assist and we can publicize, and but there's no reason why we should only be talking running these calls for prostate cancer. So I'm just putting that germ. You'll probably hear me say this a few times going forward until you're sick of it and you'll be able to give the speech yourself. Okay.
One comment that I'd like
Yes.
to make is that Bill's talk about genomics and genetics.
Yeah.
I used to teach genetics in graduate school, so I'm familiar, and it brought back a lot of memories.
Well, you shouldn't have said that, because now we'll make you another go-to person on this as well. There you go. You better be swatting up.
That's 50 years ago, pretty near.
It's too late. The cat's out the bag.
Okay.
Okay.
Have a good evening.
All right, guys. Take care, everybody.
Good night, Rick.
See you soon.
Night,
Bye.
Thanks, Rick.
Bye.